Welcome everyone. It's a privilege to welcome the global leader in surgical oncology. This is none other than Dr. Avanish Saklani. Dr. Avanish Saklani joins Fortis Mumbai as Director of Surgical Oncology. Welcome, Dr. Avanish.
Good morning, madam.
Good morning. So you have worked globally in a lot of renowned centers, Tata Hospital in UK, in Korea. So your experiences of global nature, how have they shaped your vision for cancer in India?
I think travel gives you an insight actually. Because I was very fortunate to be trained in India in some of the premier institutes like AM Hospital and Tata Memorial Hospital. But this is talking about in 2000, but that time the minimal invasive surgery was not there. There was no coordinated cancer care center. But then I traveled to UK where I did my training program there. And then you realize there is a coordinated organ-based system as well. So you have a combination of not just surgery, neoadjuvant therapy and radiotherapy. You learn that. Those are the time where minimal invasive surgery for colorectal cancer became a big insight. Laparoscopic came in and then robotic came in as well. So that gave you a good insight. Also, UK was very good for centralized things like pelvic exentration systems and complex cancer. I had the opportunity to work there as well. And that actually shaped my thing. And every time you finish something and you think you've learned enough. And after I'd finished my training and worked as faculty for about 12 years or so, then I went to Korea. And I was surprised because the type of tumors were very early, but their skills were legendary. They had early cancer. The robotic things were really good. I trained in robotic colorectal surgery for 1 year and gave insight. The East is different, lateral pelvic node dissection. So you get the best of it. So you have technical skills from India, and then you have academics and coordinated approach from the UK, specialized cancer services in UK, and then you have again technical expertise from things. And you combine together and you come to India, then you find the disease which you had left about 25 years back or something, or 13 years back, is different now. So the colorectal cancers have become very common. Even cancers in India are becoming quite rampant, which is very surprising. So we are trying to sort how things out. And I saw there were no early cancer. There were locally advanced cancer. And people were very reluctant to have surgery because they didn't want big scars.
Right.
So when I worked in Tata Memorial for 12, 13 years, and then we started doing minimal invasive surgery for early cancers, for advanced cancers, and we are probably the leading center in the world for minimal invasive surgery, robotic and all, and we are acknowledged world over as well. So I think we have established a benchmark standard. So traveling globally gives you insight. Some areas you learn about early cancer, something about advanced cancer, and our country is different because young cancers and advanced cancers, and you can offer robotic for early cancers and you can offer them for exentrative services as well. And so I think that gives you a good idea.
You have partially answered my next question. So your exposure into this minimal invasive and colorectal robotic surgeries, these advanced techniques. The next question comes to is how are these going to be more beneficial to patients as compared to the traditional approaches?
I think times are changing. When we were there in 2000, most people had open surgeries, even when I came back in 2000. So people had longer incision. People used to stay in ward for a bit longer. And if you have self-earning, time to return to job also takes longer.
Right.
I think the advantages of laparoscopic surgeries, of course, it is the oncological outcomes are similar to open surgery, but with robotic and lap. But however, because the incisions are small, the pain is less, and people go back discharged early. They can start chemotherapy early, and they can return to job early as well. But laparoscopy had some challenges. If you had a high BMI patient or complex pathology, then there were conversions and outcomes were not very good. I think robotic has overcome one of the advantages of this, and we have a vast experience of robotic surgery. And that is going to help with the similar advantage of laparoscopic surgery, decrease conversions. And for complex procedures, you can use those quite well. And especially in TMH, we get a lot of complex pathology or patients with high-risk features, and we can do that. So we've done extended resections, exenterations, and we go all over the world and trying to develop techniques which can benefit patients with limited mobility.
Absolutely.
Earlier on, when people were asked for exentrative services and all, they would refuse because it was complex. And it has decreased blood loss quite a lot as well. So I think it has a lot of advantages.
So with all that, here, the exposure that you have got, the expertise that you bring in, my next question, and I'm very excited to listen and hear from you, is what is it that you're bringing to Fortis?
I think Fortis is a very well-known name in healthcare industry. It has set standards for all benign thing and for cancer as well. I think Fortis, the Bangalore and Delhi have done really quite well. But ours is a huge country. Tata Memorial, of course, is a premier cancer institute and offers first-class services.
Absolutely.
But unfortunately, the access to that is limited in view of the long waiting list and a huge population. We hope to reproduce such services from Tata Memorial Hospital and Fortis Cancer Center. So we initially start with surgical oncology program, and then we have organ-based services. The most important thing is to get like-minded people together. People from all disciplines get together to form a team, and they decide the treatment program, and then you base it based on individual needs of the patients, not on needs of either medical oncologist or radiation oncologist. Then patient is the center of a focus. So the idea is to improve survival. If you treat only one specialty, you're probably thinking only of outcomes of surgery. If you take only chemotherapy, our idea is to improve survival. So you get many people into the program, and centers like yours, which are established here, will definitely not take the load of Premier Institute Tata Memorial Hospital, and we should be able to access people. Also in the country, if you tell someone that you have to visit the cancer centers outside and they see the vast sea of patients, they're quite discouraged, and many of them would want to go away. So most of them would like a private conversation and a free time and space to themselves. And our center offers this thing where you can give time enough to patients to discuss all the options and counsel them. And I'm sure this is the beginning. It's an early curve, and but I'm sure over the long term, we are doing a long-term vision for this.
Yes.
Changes won't be seen immediately because we are starting out, but I'm sure in a year's time, we shall be on top.
I think at Fortis, you will be able to bring the best of both places, your expertise and experience at Tata, and what Fortis will be able to add its value to it. So both together, I think we'll be able to bring that difference. So I already heard you talking about two of our organization values. One is you are living that value of innovation, and I have seen your resume extensively talks about research and innovation. And second thing was about patient centricity. So I want to hear more about what is the patient centricity that we will bring in.
I think when you travel world over, and then you see a vast sea of difference. I think patients in India somehow are younger when they come with cancer. So when you in the Western world, you're looking at patients with cancer who are 60-year-old. Here, sometimes you have someone with 35, 40. So besides oncological, you have to look at functional outcomes as well. So if I was a male and I was having pelvic surgery, I would be worried about sexual function and urinary function. And then robot plays a great role in this, where you can have well-defined functions there. And so you can use experience from abroad and use technology for patient benefit. The other thing is all these therapies also require some sort of radiation therapy as well. So if you have young females with pelvic cancer, obviously we had to save their hormonal function. So we had a great experience of ovarian transposition, relocating the ovaries in the pelvis. So you give radiation, treat the cancer, but at the same time, people's hormonal functions are still there, and they can have menstrual function, and if required, they can also have childbirth. The idea is to improve survival, and if you're young, we are looking at improving their quality of life and getting back whatever was there to them. So I think technology and healthcare in our hospital will definitely help all of them.
Yeah, that's great. So I can see the cancer care is really getting transformed, and we're moving away from the very morbid and radical surgeries to very patient-friendly kind of approach, and that's really great to hear. So the next question is going to be on particularly your expertise of advanced technology, and I read about HIPEC and PIPAC. So can we have more understanding into what are these technologies?
I think we have to realize India is growing fast, but on the whole is still a developing country. And looking at resources, we don't have national screening program. So when we did a study at Tata Memorial Hospital, we realized vast majority early cancers are only 3%, and metastatic are the same, 25% in the Western world. But locally advanced cancers, at least in a hospital, about 50% or so. And when they come, they present either with disease in the liver, for which you give chemotherapy and surgery, or sometimes in the peritoneum. So if you want to improve survival, you have to treat this advanced cancer as well. HIPEC is a sort of chemotherapy which you keep concentrated with a heated solution after removing the disease completely. Complete site reduction, which is technically good, should be done. With that, you add chemotherapy as well. It is already established for pseudomyxoma, and we probably have the largest volume in the country. But also for ovary, where a lot of evidence is coming in, or colorectal cancers and all, we also have a lot of experience in mesothelioma. So when we want to improve survival, we catch hold of every segment. For early things, we have laparoscopy and robotic. For advanced procedures, you can have robotic. For peritoneal disease, you have HIPEC. But HIPEC can be done in about few people with peritoneal metastasis, where you can remove disease completely. But there are certain patients where you can't remove the disease completely, but you can improve the quality of life. Right. So suppose if you have ascites on your abdomen is distended, you can't breathe, and this fluid keeps on collecting, and solutions like PIPAC can offer solution for this. And there's a well-studied group called PIPAC, Peritoneal Surface Oncology group, who have looked into this. So we can offer PIPAC to these advanced cancers. So at least while we may not be able to cure them completely, we can offer some amount of palliative or symptom relief. So whatever life there, they can at least improve the quality of life.
Correct. So I am hearing this lot of good discussion on having a focus on improving the quality of life of patients. Dr. Saklani, you have vast experience into Tata, which is a training institute. It's a alma mater, and you have mentored so many surgeons. So what is the message that you would want to give to the young surgeons?
I think whenever you want to move, you can move together only as a team. So if the one person can only win a battle, but if you want to wage a war, you have to train a whole team, and a whole generation of surgeons has to be there. At Fortis, I think we also have training institutes. They have DNB Surgical Oncology. You have to educate, train, and improve their technical skills as well. And that comes actually with volume. So we hope we are able to do the same sort of fellowship programs in there. With over a period of 12 years, we train many fellows all over and they are doing a leading cancer centers all across the country. We hope to continue this and use the institution to train such people. And idea is to improve healthcare across the country. We are doing our jobs, but we cannot solve the problem for the country.
Right. So get into the capacity building so that it takes care.
Absolutely.
You spoke about the MDT. I heard you talking about getting multiple disciplines together, and that would give a greater benefit to patient. So what is this MDT approach in cancer management?
With idea, with every day there's new research coming out, so there are many modalities of treating it. But every department would think like surgery would do the best. A radiation person would want to give radiation alone. Someone would do chemotherapy. But getting like-minded people and for finding out what is good in this, then you can form a patient-centric approach or a personalized approach for treatment. Especially in rectal cancer, this life has become very confusing with many trials. Someone wanted to give chemotherapy first or radiotherapy. But totally towards the end of the day, besides the oncological outcome, we are also looking at functional outcomes. So a multidisciplinary team actually evaluates the scan personally and avoids something going wrong there. Then you can plan neoadjuvant therapy. When you do surgery, then you look at things and do you require any additional therapy. There will be many people who may not require chemotherapy at all if they have complete response. So the advantage of team is you can escalate treatment if it is advanced and not responding, or de-escalate it. Certain people like young females, you just give chemotherapy, you can avoid radiotherapy. So that team-based approach, MDT, can be used either to increase the treatment, escalate, or de-escalate. So if you avoid radiotherapy, they may not require stoma and the quality of life may be good. So it's a thinking process, and every time you look at your own work as well as see, okay, what went right and what went wrong. So it's a sort of audit to actually try to correct yourself as well.
And one word which is extremely important in that, which I'm kind of holding on to, is personalized care. Yeah. I think you used that, and it's extremely important. So every patient gets a personalized care.
Yeah, that's true.
So what's a long-term vision that you have for Fortis?
I think long-term vision is to have centers like Tata Memorial Hospital. Suppose if we use a benchmark sort of center for cancer care services for surgical oncology, which will initially be for Fortis in Bombay and maybe all over the Fortis branches of the country. And this can be used by many other centers to emulate this, and many other colleagues who are doing it across various centers. I think the more we do, it is still less because there's so many people who are suffering and who have access to quality centers is low. Okay, this is the beginning. I hope we should be able to continue this well. Thank you.
So our journey towards maybe building up a center of excellence program for cancer care.
Definitely. Okay. And we look forward to your good wishes.
With more than 2 decades of experience, what motivates you even today?
I tell you what, I think sometimes you have a personal experience as well. Sometimes you have patients who come back who have done really well, and that gives you a real good joy. But sometimes what motivates you is some people you have tried to help and they have not done so well. So sometimes the drive sometimes is failure more than successes. Okay, success gives you happiness and a drive to push on. But the thing is, you need to do more, and that had probably been the driving force.
Thank you, Dr. Saklani. We are honored to have you on board, and we are excited to work with you with all your ideologies and all your plans in future. We all, support you and looking forward to develop a center of excellence for cancer.
Thank you, Bhavna. We look forward to your support. Thank you very much.
Thanks very much.